Hello everyone. We've just seen how to repair the posterior leaflet in the setting of infective endocarditis using a sliding valvuloplasty. In this next episode, we're going to build upon the bridging patch technique that we showed between the A3 and P3 commissure to handle a situation when the vegetation is actually in the opposite side at the P1 leaflet involving the A1 and P1 commissure. Let's have a look. Now, occasionally in endocarditis, patients present in quite an extreme state. This unfortunate person presented with an acute stroke with a very large vegetation that was emanating from A1 and P1 at the level of the commissure, with a vegetation not only above the valve, but also in the left ventricular outflow tract, causing embolic phenomenon. Obviously, in the acute state, we proceeded with more of an urgent approach, and you can see the size of the vegetation was quite substantial. So the first step, as always, is a full and complete thorough debridement of any and all devitalized tissue. So the perforated leaflet tissue and acute vegetation was excised. And it doesn't stop there, as one looks like there is most of the vegetation gone, but as we saw on the transesophageal echo, there was some subvalvular component. So we elected to continue and noted that there was an abscess cavity that we're unroofing right now. And here we start to see even a more concerning vegetation that is involving the left ventricular outflow tract. To help with better exposure, this is a 5-0 polypropylene suture that helps with countertraction to retract the anterior leaflet, thus exposing the underside as well as some secondary cords. And so this goes up, involving the trigone to complete unroofing the abscess. We can start to see this additional vegetation and the severity of her illness. So further debridement of the left ventricular outflow tract through the mitral orifice is performed. And once completely debrided, we'll place a few valve stitches, since we know we're going to be abutting right against the annulus. And these valve stitches are going through the true annulus, as you know, which is approximately 5 millimeters below the hinge point of the leaflet and the atrial side. And then we'll proceed with our autologous bridging patch technique. And this bridges the anterior leaflet as well as the posterior leaflet, essentially completely replacing the commissure in this case. But as you can imagine, there's a fairly large gap. Unlike the other bridging patch techniques cases we have illustrated, the gap at the level of the mitral orifice was rather small, and it allowed for utilization of existing tissues and cords. This appears to be a little more challenging in that regard. So interrupted foromonofilament sutures are utilized to complete, and again, this is an onlay patch technique, so you can see the method of suturing to somewhat bury the stitches, and then reconstructing not only the P1 area, but the entire commissure as well as the trigone. Now, there is some trigone tissue slightly on the anterior leaflet side, which we will utilize to anchor our prostheses or annuloplasty. Again, slightly oversizing the patch, because with each bite, the patch does shrink. But we did see a fairly robust secondary cord of the anterior leaflet. So much like we have illustrated in previous videos in this series, we can utilize all of these techniques in our armamentarium now to rebuild the leading edge by reimplanting this secondary fan cord to support this patch. And you can see this is implanted in the leading edge. Using a running technique, again, the same for a monofilament suture. And then to complete the onlay patch, this is more of a reconstruction now of P1. And once that's complete, we'll do the completed anastomosis to the residual tissue of the posterior leaflet. And as we've demonstrated in previous videos regarding this technique, the goal here is to provide systolic competence and allow for diastolic filling. So this avoids restriction as opposed to just sewing the two leaflets up together with a large gap. This somewhat normalizes the flow dynamics in these difficult cases. Here we see the completed repair and now starting the annuloplasty. This gets to the fibrotic material. You can see using visual feedback. We don't have true tactile feedback, but you can tell that that's very likely the fibrous trigone. And then implanting that at the appropriate location of the annuloplasty band. And then we'll complete the annuloplasty band. And then also utilize the previously utilized suture to complete the valve repair. As you can see, there is a competent valve with no significant stenosis and a mean gradient of 3.
So now we've repaired the A3-P3 commissure, the posterior leaflet, and the A1-P1 commissure. What's left? The anterior leaflet. Join us in our next episode where we're going to approach a complex lesion of the anterior leaflet with infective endocarditis.